Dr. Manu, you can initiate, you can start the program now. Dr. Manu, you can start now.
Yes. So this is the fourth part of our regular pharmacotherapy subcommittee's updates, and today's topic I think is very relevant, makes a lot of sense, because this is one medication which I've seen over a period of time growing quite nicely, and I've seen many of my non-psychiatrist friends to be using it. It's available over the counter, and it's now almost a physician product, so probably knowing it more in a deeper sense by an expert, none other than Dr. Ravi Gupta, who's an authority in sleep medicine. So will make us a better understanding about it, and probably will make us wiser. I think thanks to all the committee members, thanks to Dr. Tirthankar, thanks to everybody who's joined us. I think at the end of this seminar, we'll be much more wiser in using melatonin. And recently it has come in a number of combinations as well. So probably I really want to understand about it. I think over to Dr. Tirthankar, please.
Thank you, Dr. Manu. As you have said rightly, that we are trying to present some cutting-edge topics in our regular pharmacotherapy presentations, and today's topic is a very, very pertinent one, use of melatonin in psychiatry. And speaker is a very renowned person and is an authority in sleep medicine. So we are eager to listen his talk. I won't waste much time, and I'll hand over my mic to my moderator, Dr. Aneshak Das, and he's the gold medalist in MD Psychiatry. He's the consultant psychiatry in Guwahati, Assam, and he's the convener of Environment Psychiatry Task Force of IPS, and he was the assistant secretary of IPS Assam State Branch. He's a very dynamic upcoming psychiatrist in Assam, Guwahati, and I'll hand over my younger brother, Aneshak Das. Over to you, Aneshak.
Yeah, a very good evening to all. I welcome you all to this webinar, which is being conducted by the IPS subcommittee of pharmacotherapy. At the very onset, thank you from my earnest gratitude and regards to the subcommittee for including me as a moderator in this seminar. It's a very pertinent topic, as told by Dr. Manu. It was quite neglected prior, but it has gained popularity over the last few decades. Melatonin, it has a huge role in the circadian rhythm, as we all know, and in the maintenance of the sleep-wake cycle. We'll be knowing much more about this molecule from our very esteemed speaker, Dr. Ravi sir. Before I hand over the presentation to the chairpersons, I welcome all the IPS officers who are present here, and to introduce the chairperson, we have very learned and quite experienced chairperson. Mr. Siddharth, can you show the the first chairperson is our very own dear Dr. Soumitra Ghosh sir. He is currently the HOD of Psychiatry Department of Psychiatry, Tezpur Medical College. He was the president of IPS Assam State Branch from 2019 to 21, and the honorary secretary of IPS Assam State Branch from 2005 to 7. He has a lot of publications, almost around 32 papers in index national and international journals. He is the recipient of 3 very famous awards in India. Professor L.P. Verma Oration Award in 2019, Professor Ajita Chakraborty Oration Award again in 2019, and he is the recipient of Swami Prabhavananda Manav Seva Award in 2020, which is being given by the Bharat Seva Ashram Dibrugarh. Apart from this, he is a regular columnist in various newspapers on various mental health awareness activities. He is a regular speaker in various talk shows in All India Radio, and he conducts a lot of awareness campaign on the issues of mental health and de-addictions all over Assam. He's a poet by profession, and he has published 3 books in poetry. Apart from that, most of you must not be knowing he plays the mouth organ very well. So he keeps posting videos on playing mouth organ with various old melodies. He plays this very nicely, and you must have, if you go to his Facebook account, you will see most of the videos they are playing the mouth organ. That's all about Dr. Soumitra Ghosh, sir. Our second chairperson is Dr. George Reddy. George Reddy, he is from Telangana. He is the current president of Indian Psychiatric Society Telangana branch and the Indian Association of Private Psychiatry Telangana branch. He is the honorary consultant of various psychiatric clinics and hospitals. And he has been the past president of the Hyderabad Psychiatric Society also. And his areas of interest are substance abuse and de-addiction. And he has an interest in child psychiatry, mostly related to ADHD and autism. And these are the 2 learned and quite experienced chairperson that we have in our panel today. And I hand over the rest of the evening's program to the chairperson. They will be introducing our esteemed speaker, Dr. Ravi sir, and he will carry on with the presentation. So it will be roughly around 40 to 45 minutes that Dr. Ravi sir will be presenting. After that, we will be having the interactive sessions. If any of the participants have any queries or questions, they can put up in the chat box, and I'll be honored to present those questions to Dr. Ravi after his presentation. So over to Dr. Ghosh sir and Dr. Reddy sir.
Dr. Tirthankar?
Yes, sir. Yes, sir. Yeah.
Dr. Sab is there?
Yes.
Dr. Tirthankar, this is Dr. Dume. Please ask everybody to mute their mics.
Yes, sir. Yes. Yes, absolutely. Yes, please, everybody mute your mic except the speaker and the chairperson, sir. Please. Yeah.
Good evening. At the outset, first, when I received a call from Dr. Tirthankar Dasgupta, I think it was a delight because the IPS pharmacotherapy subcommittee is doing so many programs, and to be a part of this as a chairman, along with my senior Dr. Soumitra Ghosh sir, I think it was really wonderful. And when I heard that the topic is on melatonin, I think it's one topic I think which I think it needs to be looked into depth, because it's a picking up molecule as everyone is using, and it's also like an over-counter medicine, but still as psychiatrists, we should know the implications of this drug. And I should thank the chair, Dr. Manu Arora sir, and today's moderator, Dr. Anveshak Das, the wonderful program. And today's we have got excellent speaker, Dr. Ravi Gupta from Ravi Gupta Rishikesh. I think he needs no introduction, but still I would introduce sir. Sir is an additional professor in the Department of Psychiatry and Division of Sleep Medicine at AIIMS Rishikesh, and he has several publications in national and international journal, and a few awards and recognition to his the feathers in his cap is the mini fellowship in sleep medicine issued by American Academy of Sleep Medicine in 2010. His young psychiatrist fellowship from Japanese Society of Psychiatry and Neurology, and he has another award, Young Psychiatrist Fellowship in 2008 from WPA, the World Psychiatrist Association, and he has another award, the Indian Young Psychiatrist Award in 2008. With this few lines of introduction, Dr. Soumitra sir, are you there, sir?
Yes, sir. Yes, sir.
Yeah, Dr. I would leave the mic to you, Dr. Sir.
Yes, sir. I'm here. Hello. Am I audible?
Yes, Dr.
Hello. Am I audible?
Yes, Dr.
Yes, yes. A very good evening to everyone.
co-chairperson, I mean the chairperson, and our moderator, as well as our very wise speaker, Dr. Ravi Gupta from All India Institute of Medical Science, Rishikesh. So we are very fortunate to have you as a speaker. So today's topic is on melatonin in psychiatry. The long back, that is when we were a student, actually the melatonin was only used, it was found in pineal gland, but as the knowledge has increased, now we finding that it is also present somewhere else, also else in the pineal gland, in the retina, even in the gut and the bone marrow, etc. It was only to be used for the sleep medicines and all those, but now it is a lot of indications are coming out. So definitely melatonin is a very promising molecule. But the this talk will be very interesting, very by and thank you.
Yes, Doctor. I think with this few introduction about the topic, I think I would request the speaker to give his lecture. Over to you, Dr. Ravi Gupta.
Yeah, thank you very much, sir. At the outset, I am really thankful to the IPS subcommittee for pharmacotherapy for giving me this opportunity. And respected chairpersons, thank you very much for your kind words. And the moderator, Dr. Anveshak, a dear friend. So, say next 30 or 40 minutes, we'll be discussing about the melatonin and its implication in the psychiatric disorders. So, though we have the implication of melatonin in a number of disorders besides the psychiatric disorders, but for the purpose of this talk, I have limited myself to psychiatric disorders only. Please allow me to stop my video to improve the bandwidth of the presentation so that it doesn't get stuck in between. So in the next 30 or 40 minutes, we'll be discussing about the basics of the melatonin. Where does it synthesize? What is the pharmacology? What is the ontogeny of the melatonin? Then we will look at the evidences regarding its use in psychiatric disorders and sleep disorders. We will look at the possible mechanisms which relate the melatonin circadian rhythm with the psychiatric disorders. We will look at the different formulations which are available with the melatonin, and also we will look at the guidelines for its use in psychiatric disorders, and then I'll summarize my talk. I am currently on the advisory board of Eisai Pharmaceutical India Private Limited and Blackbeard Technologies India Private Limited. But my affiliation with any of these agencies does not influence the content of my today's presentation. So if we look at the melatonin, it is seen in all living organisms, and it has been found in unicellular organisms like bacteria, even the amoeba, to the multicellular organisms like mammals, amphibians, and it has a different, it works in a different manner at different places. At some places like suprachiasmatic nucleus, it has an autocrine role, but in the distinct visceras where it works, it has a paracrine, it works to the paracrine mode.
బంగారి పిన్ని ఫోన్ చేసిన తర్వాత చేస్తాను చెప్పు.
Please mute your mic, please. Thank you.
So it is basically amphiphilic, so that makes it a good substance to pass through the cellular membrane as well as through the nuclear membrane. So it can act directly on the receptors which are located inside the cell organelles like mitochondria as well as the nucleus. So when we talk about the synthesis of the melatonin, it is basically synthesized through the tryptophan in the pineal gland. So from the it is a basically a byproduct of serotonin, and undergoes the various kind of transformations to be the melatonin. And if we look at the pharmacokinetics, it is metabolized in the liver as the 6-alpha melatonin, and it is then excreted by the kidney through urine. Uh, Important issue is it is synthesized in the dark only. So, and any kind of light, especially the light in the blue light range, for example, the light which is getting emitted from most of the screens, they inhibit the synthesis of the melatonin, and a number of studies have shown that the people who are using the screens in the evening or the night, they actually go to bed late in the night. Now, another issue is when it is synthesized from the pineal gland, so it gets the signals from the suprachiasmatic nucleus, and the suprachiasmatic nucleus gets the signals from the retinohypothalamic tract. So the retina basically looks at the environmental light as well as the darkness, and when the retina senses that it is a dark, so it sends the signals to through the suprachiasmatic nucleus to the paraventricular nucleus. From the paraventricular nucleus, the fiber they traverse to the superior cervical ganglion, and then they come back to the pineal gland. And the superior cervical ganglion, as we all know, is located in the close to the cervical spinal cord, and the fibers they travel through the intermediate dorsolateral column. So if there is any interruption in the sympathetic pathway, that is the intermediate dorsal column of this cervical cord, that is because of any kind of injury or because of any ischemia or because of the multiple sclerosis or any kind of other damage, so that actually inhibits the synthesis of the melatonin. Similarly, beta blockers, they also inhibit the synthesis of the melatonin, because this sympathetic track that we are looking at, it actually sends the signals to the pineal gland through beta 1 receptors for inducing the synthesis or inhibiting the synthesis of melatonin through beta 1 receptors. But interestingly, when we are in a generalized sympathetic activation, for example, the flight or the fight reaction, where the secretion of the sympathetic hormone neurotransmitters like epinephrine and norepinephrine, they occur through the adrenal medulla, they do not actually influence the synthesis of the melatonin. Important issue is, unlike other hormones, it is not stored in the pineal gland. It is synthesized and released immediately when the pineal gland gets the signals of the darkness. If we look at the pharmacokinetics, so its T half is nearly 40 minutes in human. And as we have already discussed, that it is metabolized by the liver to 6-alpha toxic melatonin, which is then excreted by the urine. But if we look at the central nervous system, because most of the areas, the prefrontal cortex, the temporal cortex, the parietal cortex, the hippocampus, even the cerebellum, they are known to have the melatonin receptors, and they actually work in a circadian fashion because of the presence of the melatonin receptors. So there it is metabolized to N-acetyl 5-methoxykynanuramine. If we look at the secretion of melatonin during the subjective day, when we have the exposure to the light, we have the minimal levels of the melatonin. But as the light decreases in the evening, along with some other signals like maybe you can look at the signals from the say activity pattern, from the social rhythm, from the food intake. So they all actually give the signals to the pineal gland to start the secretion of melatonin. And the melatonin concentration is usually rises by the 8 o'clock in the evening. peaks at around 3 o'clock in the morning, and by 6 or 7 in the morning, it reaches the baseline. That means to the level which is similar to the levels of the which are seen during the day. If we look at the ontogeny, that means the synthesis and secretion of melatonin by the age, then melatonin is not available at the birth because the pineal gland is not mature. Similarly, the retinohypothalamic tracts is also immature. But at the age of 3 to 4 months after the parturition, the infant, they start secreting melatonin in a lesser amount. If we look at the prepubertal age, it is the time when the melatonin concentration in the blood in the night is at the highest level. And during the adolescence, it reaches to the level which is seen in the young adults, that is around 30 to 35 years. But at the age of 35 to 40 years, the melatonin secretion and the synthesis, it starts reducing, and it goes to somewhere around 5% of the adult level, the prepubertal level by the age of 90 years. And that is one reason we see the insomnia and the circadian rhythm sleep disorders. They appear usually in this age group, that is after the 40 years. And these people, they many a times they show delayed sleep wake phase disorder or the insomnia. Now, when the melatonin is not present at the birth, then how does the infant they maintain the circadian cycle? Well, the melatonin is absent in the fetus as well as immediately after the birth. So the fetus as well as the infants till the age of 3 to 4 years, they depends upon the maternal secretion of the melatonin. So fetus, they also also show the circadian rhythm changes regarding secretion of the various hormones as well as maturation of their various organs. So this is controlled by the maternal cycle of the melatonin, and if the maternal cycle is disrupted, of the melatonin secretion is disrupted for any reason, that also affects the growth and development of the fetus. Immediately after the birth, the infant, they get the melatonin through the breast milk, and that actually serves to to improve their circadian cycle, which gets regulated by the age of 3 to 4 months, because by that time, as we have shown in the previous slide, that the infants, they starting synthesizing their own melatonin through their own own pineal gland. Now, melatonin acts on the various kinds of organs through the two receptors, basically MT1 and MT2. We have another receptor, MT3, but its function is not clearly known. So I have not included that in the presentation. These receptors are that means they take some time to show their effect, and there is some other non-receptor mediated effects of the melatonin, as we have already discussed, that it's an amphiphilic molecule, so it crosses the cellular membrane as well as the nuclear membrane as well as the membrane of various organelles in the various cell organelles. So it crosses clear so it does not need any kind of receptors to show its antioxidant effects. So it has been found to be a free radical scavenger. It is an activator of various other scavenging mechanisms like glutathione peroxidase. It reduces the autophosphorylation, especially in the mitochondria, and that is how it actually improves the survival of different cells. It has been found to in various organs in the body, like adipose tissue, liver, kidney, pancreas, bone, skin, reproductive tract, cardiovascular system, as well as immune cells. So presence of the melatonin 1 and 2 receptors in these various organs clearly show that it regulates their functioning, and we now know that suprachiasmatic nucleus is basically a master circadian clock which actually regulates the activity of the peripheral organ through the which on all these organs they have the peripheral clock. Similarly, the MT1 and MT2 receptors, they are also seen in various other parts of the brain, and we all know that activity of all these brain parts, they also undergo the circadian variation, and that is the reason we see a change in the locomotor activity, we change in the activity of the cognition and the emotion, which is and also the sleep-wake cycle, which gets influenced by the circadian rhythm. So we all know that most of us, we feel most energetic during the day if we had a good night of sleep, and we feel tired, sleepy, and there is a dip in the alertness during the midday. And there is again another major dip in the alertness before we in the late in the evening around 8 or 9 o'clock. So that is the time when we go to bed and we feel sleepy. Now, when we talk about the melatonin's action, there are it has multiple different actions. So during the biological night, when the melatonin is being secreted, so we see a rising curve as we have seen in one of the earlier cartoons. So there we see the immediate effects of the melatonin. And now there are, besides the immediate effect of the melatonin, which basically regulates the sleep-wake rhythm, we have some prospective effects which appear the following day. And one of these prospective effects are the proximal or the consecutive effects, where it actually works to sensitize the different organs of the body for its functioning. And these effects could be related to the expression of certain clock genes like PER1. So we know that in the cells during the day, it inhibits the expression of PER1 gene, and that is the reason we keep we keep the state of wakefulness, and also it regulates the the biorhythm for the glucose as well as the insulin through acting on the beta cells in the pancreas, where it regulates the expression of the BMAL1 and alpha, which are the basic genes which regulate the activity of the circadian clock. Now, there are another kind of distal effects that we see, which are mainly metabolic, and where it actually regulates the expression of the clock control genes. That means these are not basically the clock genes per se, but the another genes which are regulated by the expression of the clock control genes, and thereby it actually influences the metabolism. And now we have certain evidence, even from the human studies, that the people who go to bed late in the night and who wake up late in the morning, that means who are following the delayed sleep-wake phase disorder, they are at greater risk for development of obesity. They are at greater risk for development of dyslipidemia and the diabetes mellitus, or a disruption in glucose metabolism. If we look at various actions of the melatonin, it influences almost every organ of the body, because as we have already discussed, the different organs of the body, they have their own circadian clock, which is regulated by the master clock, that is the suprachiasmatic nucleus. So in the liver, it actually influences the gluconeogenesis, glucolysis. In the adipose tissue, it influences the sensitivity of the adipose tissue to adenopoectin, and also it influences the insulin sensitivity in various muscles. So that is how it regulates the various kinds of metabolic cycles. If on the right side of the cartoon, you can see the basic the circadian clock, the molecular clock that we see in almost every cell of the body. and also in the suprachiasmatic nucleus. So if we look at the basic clock, it has basically one positive loop where we have the BMAL1 and the clock genes, which regulate or increase the expression of the PER and the CRY gene. Now, this PER and the CRY products, they are translated into the protein, and they translocate themselves in the cytosol in the cell, and in this cytosol they gets degraded. But when they reach to a critical level, then they get translocated themselves to again to the nucleus, where they reduce the expression of the BMAL and the clock. So we have a positive loop and a negative loop, and then we have some auxiliary loops which also control the expression of the either the BMAL1 or the clock gene or or the PER and the CRY gene. And this is how we maintain a sleep-wake cycle throughout the day. If we look at the role of melatonin in psychiatric disorders, so a number of studies have been conducted which clearly mention that melatonin and the clock genes, they are related to the expression of the various psychiatric disorders. So let's examine these evidences. So if we look at the major depressive disorder, clinically, we see that insomnia is common in the major depressive disorder. Many of the patients with major depressive disorder, they show the phase advance. That means they go to bed early in the night and they wake up early. So terminal insomnia, what we see in patients with depression, could actually be a advanced sleep wake cycle. Similarly, some of the patients with insomnia, they complain of difficulty falling asleep. And when they are allowed to sleep according to their own sleep wake rhythm, then they wake up late in the morning. And that is an evidence for the phase delay that we see in the depression. Similarly, a reduction in the RAM latency as well as increase in the RAM density, which has been seen in the depression. So all these clinical evidences, they show that there has been a role of the circadian cycle in the patients with depression. And number of studies have shown that PER1, PER2, PER3, BMAL, clock gene, NPAS gene, and the CRY2 gene. So polymorphism in all these genes, which we have recently discussed, that they control the circadian clock, it has been found to be associated with the occurrence of the depression compared to the healthy control. Similarly, clinically, we see that the RAM latency is reduced in the bipolar disorder. Many of the patients with the bipolar disorder, they wake up early in the morning, so that shows the advancement of the sleep-wake cycle. Many of the patients with bipolar disorder, whether they are in the phase of mania or depression, they show irregular sleep-wake cycle. That means they sleep for some time in the night, then they wake up, then they again go to sleep for a couple of hours, then they wake up, then they sleep in multiple small naps during the day, and that shows the irregular sleep-wake cycle. Similarly, many of our patients, they show that they have the symptoms of either depression or mania, which appear in a cyclical fashion and which are affected to a particular season. For example, some patients, they report that they have the manic episodes mainly in the summers. Other report that they have the depressive episodes during the winters, or vice versa. So this shows that there is a periodic appearance of the symptoms, and which could be regulated to the melatonin, because the melatonin secretion is dependent upon the light, as we have already discussed, and the amount of light that is falling on the retina, as well as the duration of the light that is falling on the retina, that can actually influence the secretion of the melatonin rhythm. For example, during the winters, when the say the days are shorter, the total amount of light cumulatively which falls on the retina is reduced, as opposed to the total amount of light that fall upon the retina during the summers when the days are long and the nights are shorter. So that shows that circadian variation or the circadian clock might be influencing the occurrence of the bipolar disorder. And the studies, various studies have shown that the different kinds of genotypes of various genes like GSK3, PER2, the RORB, CRY2, CRY2, and PER3 are associated with the occurrence of the bipolar disorder compared to the healthy controls. Seasonal affective disorder, we all know that some patients, they may show depression at a particular season, either in the summers or the winters. And this has been found to be associated with the polymorphism of PER2, BMAL1, and NPAS2 gene, all three genes which are basically control the circadian expression as well as the circadian cycle. Uh, we commonly see the patients with schizophrenia, and we commonly see that these patients, they go to bed late in the night and they wake up late in the morning. Many a times we misperceive this difficulty in falling asleep as the insomnia. But if you say do collect the data through an actigraphy which shows the activity rhythm of the people who are suffering from schizophrenia, then you will find that these patients, they are not actually suffering from insomnia, but what they show is basically a phase delay. And if the studies which have accumulated the data regarding the melatonin secretion throughout the night, they have found that these patients, they have a blunted circadian variation of the melatonin. And that could be one reason that these patients, they are not able to perceive the difference between the night and the day. And that could be one reason that they are having, say, delayed sleep phase disorder. And similarly, the clock gene PER1, PER2, PER3 gene, and as also the cryptochrome 1 and 2 gene, and the rever alpha, all polymorphisms in these genes have been found to be associated with the schizophrenia compared to the healthy individuals. If we look at dementia, of course, we do not have any data from the genomic studies, but patients with dementia, they show increase in the REM latency, they show sleep fragmentation. Their symptoms, they usually worsen with this with the evening or the sunset. They have been found to show the phase delay of the temperature rhythm, and because of the neurodegeneration, they have the reduced amplitude of the melatonin rhythm. But when we look at the clock genes, there is no difference in the circadian expression. But the clinical evidence suggests that even in the absence of the clock gene, for the reasons unknown so far, the circadian system, it plays a role in the occurrence of the sleep disturbances and appearance of the other symptoms of the dementia. Similarly, say even in the healthy individuals, we know that the cognitive functions, they run in a particular cycle. So we are most cognitively aroused during the morning. Then during the afternoon, we see a dip. And again, there is an improvement in the cognitive functions in the evening, which goes again, there is a, which show a dip late in the evening, and that is the time when we feel sleepy. So both these evidences, they show that circadian clock might be playing a role in dementia. Patients with the ADHD, they show a refusal to go to bed. So many a times we consider them as the initial insomnia. And this bedtime refusal can also culminate in going to bed later at the night. So many of these children and the adults, they go to bed late in the night, and many of them, they wake up early. So these clinical data again suggest that there is a problem with the circadian system, and this number of the circadian genes, they have been shown to be associated with the occurrence of ADHD compared to the healthy individuals. Now, coming to autistic spectrum disorders, sleep problems are not uncommon among the patients with autistic spectrum disorder, and the clock genes have been found to have different kind of polymorphism, and these polymorphism, they have been shown to be associated with the occurrence of the sleep problems in autistic spectrum disorder. Now, we have looked at the clinical as well as the laboratory evidence for the association between various kinds of psychiatric disorders, as well as the circadian clock, genes, and the circadian system. But what are the neurobiological links? So this is a very good review which is available online, and it is it's an open access paper. And I would urge that all the people who have joined, they should actually read this paper. So I have taken this cartoon from the adolescence because that is a time when brain is undergoing maturation. So that is a time when the different kinds of functions, they are undergoing maturity, and that is the reason we see that their cognitive functions, their emotional mechanisms, as well as the impulsivity, they are high. And we know that the various kind of neurotransmitters, especially the dopamine, it undergoes a circadian variation in the synthesis. So synthesis of the dopamine reduces in the evening, and that could be one of the reasons that the mood regulation, it is influenced by the circadian genes and undergo the also the reward mechanisms, they also at the lowest in the evening. Now, this reward in mood regulation can actually lead to the occurrence of the psychiatric disorders like substance use disorders, depression, anxiety, bipolar disorder, and schizophrenia. A number of studies have shown that the patients who are suffering from any kind of substance use disorder, their preference to substance use increases mainly in the evening. And many of these patients, they show the delayed sleep wake phase kind of circadian rhythm. And also the people who are following the delayed sleep wake phase kind of rhythm, that means who go to bed late in the night and wake up late in the morning, they are prone to develop depression and substance use disorder, besides many other medical disorders like diabetes, hypertension, CAD. Now, this kind of cognitive control and mood regulation could be influenced by the variants, polymorphism, as well as the expression of the circadian genes. And all these changes in the circadian genes, they can also influence the circadian rhythm as well as the sleep timing. And the sleep timing, sleep duration, the circadian rhythm, they can also lead to the occurrence of the psychiatric disorder. So here we have the circadian rhythms as well as the sleep wake cycle, which is a bidirectional relationship with the occurrence of the psychiatric disorder. So this article suggests that the routine activity as well as the time light exposure as well as the timed melatonin, which can actually regulate the circadian system, they can actually lead to some kind of improvement in various psychiatric disorder, and the evidences we shall examine in the subsequent slides. So far we have discussed the basics about the melatonin, we have discussed about the evidences that how the circadian rhythm, circadian clock genes, they are actually related to the occurrence as well as of the psychiatric disorders. Now we will look at whether the melatonin or its agonists, they actually help in the treatment of psychiatric disorders or not. So one of the major effect of the melatonin is the chronobiotic effect. Chronobiotic means it actually regulates the sleep-wake cycle, what time we go to bed and what time we go to and what time we wake up. So as we have discussed earlier, during the physiological time around 8 o'clock in the evening, the secretion of the melatonin starts, which reaches the peak around 2 or 3 in the night, and it reaches to the basal level around 7 or 8 in the morning. So before this period, when it is rising, before 2 to 6 hours, if we ingest the melatonin, that is the time where we can actually advance the sleep-wake cycle. So if your patients are suffering from delayed sleep-wake phase disorder, please give them melatonin, prescribe them melatonin somewhere between 3 o'clock in the evening to around 8 o'clock in the night, or to be on safer side, between 3 to 7 p.m. If you prescribe the melatonin, it will lead to the phase advancement. On the contrary, if you prescribe the melatonin in the early in the morning, that will actually delay the phase. And so in patients who are suffering from advanced sleep-wake phase disorder, you can use melatonin in the morning. You can prescribe it in the morning to delay their phase. So this is how we use melatonin in the two major sleep disorders: advanced sleep-wake phase disorder and delayed sleep-wake phase disorder. Melatonin is available in various formulations. For example, it has an immediate release tablet which are available in India. So these tablets, they are available in the doses of the 3 milligram, 5 milligram, and 10 milligrams. In certain European countries, we have the prolonged release or the sustained release tablets. In India, we also have an oral spray which is being manufactured by one of the company. Then we have nasal spray, skin patch or the cream, as well as the anal suppository formulations of the melatonin. But if we talk about the India, we have only the oral spray as well as the immediate release tablet. If we look at the evidence, so these are the consensus guidelines which were published recently, and they report that when the patients with mood disorders, if they are suffering from comorbid insomnia, again, that is one of the major disorder that we usually consider insomnia as one of the symptoms of mood disorders, and we do not diagnose the comorbid insomnia, while the recent clinical data clearly suggests that if a person with depression or bipolar disorder, if he's concerned with the symptoms of the sleep, and if they are having the daytime symptoms, then the independent diagnosis of comorbid insomnia with mood disorder should be made. So in those cases, it has been suggested that the prolonged release melatonin, which is a dose can range between 2 to 10 milligram, 1 to 2 hours before bedtimes, it can actually improve the insomnia symptoms or the comorbid insomnia syndrome. It also helps in discontinuation of sedatives and hypnotics, because many of us do not want to give the sedatives or the hypnotics, that is the benzodiazepines, to these patients, considering that the hypnotics can actually be an addictive substances. And so in those cases, when you are planning to discontinue the sedative hypnotics, if you include the melatonin, it can improve the sleep quality during that period. But when you are giving this melatonin, always take into consideration the chronotype of patient. For that, you can use a freely available scale, the morningness and the eveningness questionnaire. So people who are of morning type, they should be given melatonin early in the morning, and the people who are of the evening time, they should be given melatonin late in the evening. With the immediate release melatonin, the results are uncertain, but as of now, we have no choice except to prescribe this unless we have the SR formulation available in India. Many of the patients with the mood disorders, they also suffer from circadian rhythm sleep disorders. And in those cases, the immediate release melatonin in less than 1 milligram of the dosage should be used because the chronobiotic doses of the melatonin are usually smaller than those of the doses that we use for the insomnia. And the ideally, we should calculate the timing of the administration to the dim light melatonin onset. But again, that's an invasive investigation. We cannot do it. So clinically, what you can do, either you can ask the patient to complete a sleep diary following his own sleep wake schedule for 1 week, and that will give you an idea whether the patient is following the delayed sleep wake schedule, or it is showing the advancement in the sleep wake schedule. So when the patient is showing delayed sleep wake schedule, you prescribe the melatonin early in the evening. Otherwise, early in the you can prescribe it in the morning time. When we talk about the anxiety disorders, a number of patients, they suffer from insomnia. But as of now, we do not have the well-conducted randomized controlled trial to show the efficacy of the melatonin in treating the insomnia in patients who are suffering from comorbid insomnia. But the clinical evidence suggests that it might be useful in treatment of the insomnia symptoms or comorbid insomnia. And if the patient is having any kind of insomnia disorder and is aging more than 55 years, in those cases, you can use 2 milligram of prolonged release melatonin 1 to 2 hours before the bedtime. Now, we have to look at the pharmacokinetics between differences between the immediate release melatonin and the prolonged release or the sustained release melatonin. Melatonin is actually having a short half-life ranging between 20 to 40 minutes. So immediate release melatonin is having a short half-life. But when we are using the prolonged release melatonin, its half-life increases up to 2 hours. And that is the reason there is a difference in the use of the prolonged release melatonin and the immediate release melatonin. Similarly, a number of patients with the anxiety disorders might be suffering from circadian rhythm sleep disorders like delayed sleep wake phase disorder. And in those cases, the chronobiotic dosage of melatonin in less than 1 milligram may be used. Again, the timing of the administration should be calculated using either the morning eveningness questionnaire or using a sleep diary or the actigraphy, which is available or whatever is available with you. If we look at the adult ADHD cases, again, there are no well-conducted RCTs, but the immediate related melatonin ranging in a dose ranging between 2 to 6 melatonin before the bedtime could actually promote the sleep in these cases. Many of these patients, as we have already discussed, they show the delayed sleep wake phase disorder. So in those cases, the immediate release melatonin may be given late in the evening for 3 weeks. And then after that, you can actually start advancing the timing of the melatonin administration by 1 hour till the patient reaches to the desired sleep wake schedule. If we look at the autistic spectrum disorder, there are no well-controlled trial among the adults, but the prolonged release melatonin, ranging between the 2 to 5 milligram of the doses, 1 to 2 hours before the bedtime, could be useful in the treatment of the insomnia if you do not want to prescribe the hypnotics and the sedatives. One of the major issue is the delirium. So in the treatment of the delirium, especially when the patients they are suffering from insomnia or the circadian rhythm disturbances, you can use the prolonged release melatonin 2 milligram or the immediate release melatonin 2 to 5 milligram. Again, early in the evening to normalize their sleep-wake cycle. And the patients who are at risk of developing delirium, in those cases, you can also use the melatonin, and it has been shown to prevent the incidence of the occurrence of the delirium. And that could be a very good technique to prevent the delirium, because once the patient they get delirious, many a times it becomes very difficult for us to say treat the delirium, especially the sleep-wake cycles in those cases. If we look at the neurocognitive disorders or the dementia, many of these patients, they suffer from the insomnia or circadian rhythm sleep disorders. So in those cases, you can use either the prolonged release melatonin or the immediate release melatonin. But again, these patients, they show different kind of sensitivity to the doses of the melatonin. So doses should be cautiously titrated, because many of these patients, they become sedated by doses as low as 3 milligrams or 3 milligrams of melatonin. In these patients, it has been shown to improve the behavioral disturbances that we see usually in the evening. And the prolonged release melatonin 2 milligram can actually be very useful in the patients who are suffering from idiopathic Parkinson's disease. And in those cases, it has been found to improve the sleep quality as well as the occurrence of the REM sleep behavior disorder. REM sleep behavior disorder is one of the disorders where the patients, they act on their dreams. They can get indulged into a kind of violent behaviors like kicking their bed partners, slapping their bed partners. They may get out of the bed. They may indulge into the fights. And when they are woken up, they can at times recall the dreams that they were dreaming, and these dreams are usually showing these kind of activities, and that is a reason it is known as enacting on their dreams. Patients with substance use disorder, as we have already discussed, that the patients with the substance use disorder, they have shown to be suffering from the delayed sleep wake phase disorder or the delayed sleep wake phase, the circadian kind of cycle, and a different kind of the clock genes, they have been shown to be associated with different kind of substance use disorder, especially the alcohol, cocaine, amphetamine, and stimulants. So in those cases, if they are suffering from insomnia, you can use prolonged release melatonin 2 milligram 1 to 2 hours before the bedtime. It can also be useful during the discontinuation of the hypnotics, as we have already discussed, for the discontinuation hypnotics in patients with major depressive disorder as well as the anxiety disorder. If these patients are showing circadian rhythm sleep disorders, then it could be useful in the chronobiotic doses, and the timing of administration should be calculated using the sleep diary or the actigraphy, or through the dim light melatonin onset, but again, that is not feasible. It is not, as we have already discussed, patients with schizophrenia, they actually do not suffer from comorbid insomnia, but they actually suffer from delayed sleep wake phase disorder. So in those cases, you can use the prolonged release melatonin 1 to 2 hours before the bedtime. And also you can use, if they are showing circadian rhythm sleep disorder, you can use the melatonin in the chronobiotic doses. In depression, melatonin as well as the melatonin agonist like remeltion, And tell me, Satya, they have been found to resynchronize the circadian rhythm, as well as some of these studies, they suggest that they alleviate the symptoms of depression. This is an important topic that we should discuss because many of the patients with depression, they actually show the delayed sleep wake phase disorder. That means they show the initial insomnia, they go to bed late in the night, but to get indulged into the social activity, they follow the social rhythm, and that is the reason they wake up early in the morning, and that makes them sleep deprived. And this sleep deprivation can mimic many of the symptoms of depression, like reduced energy, fatigue, tiredness, headache, poor concentration. So these patients, they at times can be mistaken for the depression, and that is the reason that it has been found to alleviate symptoms of depression in many of these patients. Some preliminary evidence suggests that melatonin can improve the aggression, irritability, as well as anger, especially in the children. But so far, we do not have any definitive data. So we cannot say that we can prescribe it in the patients who are suffering from any of these symptoms or the disorders characterized by any of these symptoms. We look at the safety data. It has been found to be safe in the short term, even in the extreme doses. Extreme doses means 50 milligrams or 200 milligrams per day. In these patients, it has been shown to have the adverse effects which are commonly seen in proportion similar to that what we see in the placebo groups. The common adverse effects are the sleepiness, headache, nausea, and the dizziness. But the safety of exogenous melatonin is not established in children, adolescent, during the pregnancy as well as the breastfeeding. So we have to be a bit cautious when we are prescribing melatonin to this age group or to the pregnant or the breastfeeding female. So in summary, melatonin is basically a neurohormone which has multiple actions besides controlling the emotion, cognition, sleep-wake cycle. It has antioxidant property. It regularizes the various metabolic parameters in the body, and many other roles which it play are still to be investigated. Preliminary evidence suggests that it has a role in the management of either the insomnia or the sleep-wake phase disorders or the psychiatric disorders per se, but further research is required till the time unless we say that it is having a definitive role in the occurrence of the psychiatric disorder. With these words, I conclude my presentations. Thank you very much once again for providing me this opportunity. And I hand over the podium to the chairpersons.
Uh, Thank you, sir. That was quite
Thank
an yeah.
you, sir,
Hello.
for your nice deliberation. Hello.
Yeah, thank you, Dr. Ravi sir, for such an enriching and insightful detailed lecture on melatonin. Now I hand over the proceedings to Dr. Soumitra Ghosh sir and Dr. George Reddy sir, and for their comments.
Yes, I think at the outset, it was a very detailed presentation, and thanks to the speaker, so much in detail. I think so many new insights I could learn from the presentation. Excellent presentation, Dr. Sir. I think it was so useful, so many take-home points. And I think with your presentation, definitely the use of melatonin in my personal, private practice, I think it should definitely enhance. So many take-home messages. Thank you, Dr. Sir. Dr. Soumitra, sir.
Thank you, Dr. Ravi Gupta. A lot of things about in details as already said. So without wasting time,
Sir, your voice is not audible properly. Ghosh sir.
Yeah, Dr. Anveshak.
Yes, sir. So can we
That's up,
go
I
with the
think,
question
thank
answers?
you.
we'll go to the
Yes,
question
yes.
answers
Yeah,
because
I see
think that's up.
I see 2-3 questions in the chat box. The first one is by Dr. Dr. Ravi sir, are you there?
Yes, yes, I'm here.
Yeah, the first question is, does melatonin influence the molecular clock? And that's not really the circadian clock genes. Molecular clock is a single gene, a single cell, and they are cell oscillators regulating the cell cycles, metabolism, and various other cellular function. So your comments on this question, sir?
Yes, I think I've already discussed that the clock genes are present in every cell in the body, but these are known as the peripheral clocks, which get synchronized with the environmental timing through the entrainment from the suprachiasmatic nucleus. And suprachiasmatic nucleus itself also has the MT1 and MT2 receptors, and that is the reason melatonin, it regulates its own production, and that is the reason we see a circadian variation in the the melatonin production of the through the suprachiasmatic nucleus.
Thank you, sir. I guess this makes the answer very clear. The second question is the maximum uses dose of melatonin and including the range in various disorders. I think this has also been discussed, but again, it will be a repetition of whatever you have presented, sir.
Yes. So, say so far, whatever evidences we have discussed that we can use the melatonin, especially in this, if possible, preferably in the sustained release formulation in the doses varying between 2 to 6 milligram for the insomnia and the benzodiazepine discontinuation. If we are treating the case for the delayed sleep wake phase disorder or advanced sleep wake phase disorder, then we should use the chronobiotic doses, which are less than 1 milligram per day. And as far as the maximum dose is concerned, well, there have been studies, especially among the cancer patients, and the studies which have looked at the anti-inflammatory effects, especially during the COVID-19, which have prescribed melatonin in doses up to 50 milligram per day. And some of the studies they have given up to 200 milligrams. But again, since we do not have multiple RCTs and a meta-analysis regarding that, so we can't say that these doses can be given to the patients who are suffering from psychiatric disorder.
Thank you, sir. I see only these 2 questions in the chat box. If any participants present wants to raise any other questions or comments,
Yeah,
you can
that's
definitely ask. Yes, sir. George Reddy, sir, please.
Yeah, that's up. Thank you. That's up. The question is in treatment of ADHD in an adult ADHD. Usually, they have a lot of comorbid sleep disturbance, and how would you place this melatonin, doctor, particularly when an adult ADHD has a problem in sleep maintenance? Like, what would be the role of melatonin, and the dose, and when they have to take the medication?
Sir, if we look at the consensus guidelines that I have already shared, it clearly suggests that melatonin may be given, the prolonged release formulation of melatonin may be given in the doses of 2 to 6 milligrams if we are looking at the insomnia, and in the chronobiotic doses if we are looking at the circadian rhythm sleep disorders. And say number of studies have systemic reviews, they have also shown that melatonin may be co-administered with other psychotropic medications, and this co-administration of melatonin has been found to be safe, at least in the short term.
Right.
Yeah, Thank you, sir. I see another very interesting question, and that is from our respected chairperson, Dr. Ghosh, sir. If a child is not breastfed, then what happens to their sleep-wake cycle?
Well, I'm sorry, I do not have any ready-made data available on this or something which I can recall. I need to see it. But whatever the evidences we have looked into, they clearly suggest that say till the age of 3 to 4 months, because they are not getting the melatonin from the mother, so their sleep wake cycle may get a little time to get synchronized with the environmental timing till they start having production of their own melatonin, that is by the age of 3 to 4 months of postpartum.
Okay, sir. Thank you, sir. Another question coming up is that, sir, does ordinary tube lights also affect melatonin
Yes,
secretion?
there have been some of the studies which clearly mention that the light as low as 5 lux in the intensity can actually inhibit the secretion of melatonin. Recently, I've got a paper which mentions that if you are sleeping, even with your eyes closed in a room where you have the nighttime night bulb, even that can derange your metabolic parameters compared to the people who are sleeping in absolute dark.
Yeah. The another question is that can melatonin be given as an add-on in MDD, and if yes, then what is the dose?
Of course, you can give in the along with the other medications because melatonin is a hormone, so we do not have much idea about its drug interactions. And the another problem is, especially in the US, it is available as a over the counter medication or over the counter product. So we do not have any idea about its drug interactions, but it can be given, and the doses depends upon whether you are giving it for the insomnia or whether you are giving it for the delayed sleep wake or the advanced sleep wake phase disorder.
Okay, sir. Uh, mm, then two more questions coming up. Can we augment the circadian rhythm with darkness and bright light plus melatonin?
Of course, I mean, if we look at the management, the American Academy of Sleep Medicine's guideline for the management of circadian rhythm sleep disorder, they clearly mention that melatonin is chronobiotic, no doubt. But as of now, we cannot say that melatonin alone can help in resetting of the circadian rhythm unless we use the social rhythm therapy, unless we use the light therapy for the management of the circadian rhythm sleep disorder. So all the three techniques, they should go hand in hand for the management of CRSD.
Yeah. Then another question is the role of melatonin in ASD.
ASD, that means autistic spectrum disorder. Yes.
Correct, sir.
So as we have already discussed, in the autistic spectrum disorders, the children, many of them, they have the altered sleep-wake rhythm or suffer from insomnia. So in those cases, the melatonin may be used, but again, that is because we don't have any safety data available in the children and the adolescents. So that could be a kind of say use that which is against the available guidelines. But in the adult ASD, since we have the safety data, so it can be used, and we have already discussed that in the presentation.
Uh, uh, Next question that comes up is the dose of melatonin to be prescribed for child and geriatric issues.
In the children, again, we should start from the lowest dose possible because again, that we don't have much data about it, but the papers they have suggested the use ranging between 1 to 3 milligrams. But I could not find any meta-analysis, so I did not include that part in the presentation. Regarding the geriatric patient, again, as I've already discussed, they can be very sensitive. So the dosage should be lowest as possible, and you should keep a watch on the possible adverse effects. That is the sleepiness, headache, dizziness, and then you can gradually increase the dose considering the clinical improvement.
Yeah,
Then,
that's one question.
yeah, Reddy sir, please.
Yeah, that's it. Now when it's clear that the melatonin is available over counter, that's it. Still, do we still need to worry about the role of indication? Like for example, just now you were saying that not much of data in children with ASD and in the child population. Should we be careful, Doctor, in the future for any medical legal issues, particularly?
Sir, I think again, if we talk about the India, it is not available OTC, but only as a drug formulation. So I think we should be little careful. But even if you are using in the pediatric age group, there are a number of papers which are available and which show that the children can actually improve with the use of melatonin. So I don't think so there should be any kind of medical legal issue with that.
Thank you, Doctor.
And I
Thank
do
you.
not.
Then I guess this will be the last question by Dr. Sunny Dua. Your take on use of melatonin in olanzapine-induced metabolic syndrome.
Well, if we talk about the metabolic syndrome induced by the olanzapine, that actually follows an altogether different kind of pathophysiology. One, it increases the appetite. Second, it leads to the weight gain that leads to the OSA. And it also actually sensitizes the abdominal, these corticoid receptors. So it increases the deposition of fat in the abdomen, which actually leads to the, change in the glycemic control. So addiction of melatonin may not work in the, theoretically at least, may not work in the metabolic syndrome associated with olanzapine, but we have to actually look for the other factors, that is the weight gain, the sleep apnea, if we want to control the metabolic syndrome in those cases. But this is again a theoretical information. At least I do, to best of my knowledge, there is no data available regarding the use of melatonin and the control of metabolic syndrome in these patients.
Thank you, sir, for your insightful answers. If there are no more questions, any last comment by our respected chairpersons, Dr. Reddy sir and Ghosh sir, or else I can hand over the
Thank you.
proceedings to Dr. Tirthankar Dasgupta sir for his concluding remarks and vote of thanks.
I think I should definitely thank the pharmacotherapy subcommittee for selecting a wonderful speaker. And thank you, Dr. Tirthankar, for giving me an opportunity to be the chair here. And an excellent presentation, Dr. Thank you. Over to you.
Thank you so much. And yeah, yes, sir. Thank you so much. And it's been such a wonderful and a brilliant talk by the authority of sleep medicine, Professor Ravi Gupta. And it was so informative and so insightful. We learned a lot of new aspects we learned. And hopefully we can arrange another different aspect of sleep disorder, cutting edge topic related to pharmacotherapy. And now I hand over my mic to Dr. Manu Arora, my chairperson. Dr. Manu, are you there? Yes.
Yes,
yeah.
yes.
Yes. Yeah.
I was actually giving my lecture only in between. I had to speak on Kerispec. So I had only been partially able to follow the topic. So what I'll do is that I'll go again through the topic, but I do understand that I need more knowledge to use melatonin. Probably I'll be enlightened because I did not go because I was giving my lecture. So probably I'll go through it and then I'll come back to it. Please continue.
Yes. So shall we conclude the session?
Yes, please.
Yes. Thank you everyone for joining this wonderful session. And we will upload this entire presentation in our YouTube channel of Pharmacotherapy Subcommittee. So you will get all the recording version of this entire talk. of this brilliant talk. Thank you so much.
Thank you
Thank
so
you.
much.
Thank you.
Thank you. Thank you very much.
Siddhartha, you can stop the recording now.
Okay, sir.